Good evening. Welcome to this ESOT webinar on developing living kidney donation. I am Paolo Rigotti from Padova, and in this webinar, I'm acting as a creator only. So I'm pleased to introduce the real moderator, Dr. Frank Dorr from the Imperial College of London, and the three speakers, Dr. Lluís Guirado from Barcelona, Dr. Enrico Benedetti from Chicago, and Dr. Emanuele Cozzi from Padova. Frank, it's your job. Grazie,
Paolo. Welcome, everyone. My name is Frank Dorr. I'm a transplant surgeon in London at Imperial College and Hammersmith Hospital. It's indeed a real pleasure to do this together, Paolo, and to see if we can get lots of engagement from our participants. Please use the Q&A button in your Zoom screen, as you probably all have done in the past, rather than the chat function, because we can then follow up with the Q&A session later. So let me allow me to introduce the first speaker, who is Professor Lluís Guirado, Director of Nephrology and the Renal Transplant Unit at the Fundació Guiber Hospital in Barcelona. And I'm sure you've all seen him before, and today he will speak about the evolution of living donor selection. Lluís, the floor is yours.
Okay. Thank you very much to the ESOT and Professor Rigotti for inviting me to participate in this webinar. My issue is the evolution of donor selection, the changing profiles of our living donors. I don't have any conflicts of interest regarding this presentation. As you know, we have increased a lot the number of our recipients in our waiting list. And to compensate and transplant these patients, we have tried to increase our deceased organ donors. Spain has been leading the last 15 years this organ donation in the whole world, but these deceased organ donors are not enough. We have also tried in Europe to increase the number of our living donors. And I can say that at least in my country, together are not enough. And let me show you what has happened. Looking the red line in Spain is the kidney waiting list. We only have been able to decrease 15% our waiting list in the last 15 years, at the moment that we have increased a lot the number of our renal transplants. And it seems that we are transplanting every year almost the whole list. And of course, this is not true, because we transplant one patient, we replace immediately this patient, especially with expanded criteria recipients. And in 1 year, we have had in our waiting list, and as I show you here, 7,000 recipients, but we have only transplanted 50% of them. That means that we need in our country at least 2 years to transplant a patient. This is the reason to increase our living donors program. And this is the issue that I'm going to comment in my talk. Sometimes we have a candidate very easy to decide if it's acceptable for living donation. In this case, is the green one, candidate A. This is a good candidate, and the majority of centers are going to accept it. At the other side, we can have the candidate C. This is a very bad candidate, and the majority of centers are going to refuse it. But in the middle, we have the yellow one, the candidate B, that is in the border. For some centers is acceptable, for some centers is not acceptable. And perhaps we have been changing the threshold to accept these potential living donors in some countries. Let's go to the first point, the age of the donor. Is there a maximum age of our living donors? The answer is clear for the majority of guidelines. There is not a maximum age for our living donors. KDIGO guidelines, no mention for the age of the donor. And for British guidelines, we have the advice that old age is not a contraindication alone, but our patients have a greater perioperative risk than all living donors, and possibly renal function is worse for his recipients, and possibly the duration of this kidney is also a low duration. For Europe and for USA, no maximum age is the only point that we have a consensus. No maximum age for our living donors. I show you here what has happened in UK and in USA the last years. The age of our living donors has increased, and in my country, the last 10 years, the age of our living donors has increased 4 years, and also the age of their recipients. And we have introduced this new category, the blue one, with all living donors being more than 70 years old, and some of them more than 80 years old. That was incredible 10 years ago. And you know that if you are using all living donors between 75 and 85, the GFR before nephrectomy is lower. The mean in my country is 75 milliliters per minute. And you have at this moment to decide if you can accept these all living donors for young recipients or just for an all-for-all program in living donation. What has happened in real life? Look at between these years, these 10 years, almost 2,000 transplants. When we have living donors older than 70, the majority of recipients, the blue one, are older than 70, all for all. In some cases, between 60 and 69, the recipient. Normally is the couple of the donor, sometimes the brother or sister. But look at here, sometimes the age of the recipient corresponds to the age of the son or daughter. And my question for you, is that a bad policy to use all living donors for young recipients? And I think that the answer is no. And let me show you why. This is a Swedish study comparing donors, living donors with good GFR over 80 milliliters per minute, probably young donors, comparing with all living donors, GFR below 80, and of course, the result is better for young living donors, but when you compare all living donors with deceased organ donors, the results in terms of graft survival is just the same. Then, for me, this policy, all living donor for young recipient, could be acceptable, individualizing, of course, the case. The second point, renal function. Is there a minimum GFR for our living donors? That depends. For KDIGO guidelines, the minimum is 60 milliliters per minute, and you have to individualize between 60 and 90. British guidelines introduce a new concept, in my opinion, also interesting, is that post-donation GFR has to remain between the gender and age normal range for the rest of the life of the donor. That means that it's not the same 75 GFR if your potential living donor is 75 years old or 35 years old. You have to individualize. For the rest of guidelines, the opinion is just the same. You know very well this slide. Becoming a living donor increase the risk of end-stage renal disease comparing to healthy match non-donors. But you have less risk than general population. This is very well known. But if you become a living donor, you increase your possibilities of developing chronic renal failure. To predict the possibility of developing this renal failure, you have different calculators. Some of them calculate the risk of end-stage renal disease without donation, and some of them the risk of chronic renal failure after donation and also of developing proteinuria after donation. And This is very useful to help us to give advice to our potential donor and recipient. Real life. That's Spain. This is a period of time of 10 years between 2000 and 2010, comparing GFR of donors, young donors and old donors. Before nephrectomy, GFR is different, 10 points. They decrease GFR less than 50% after donation, but look at that 10 years after donation, GFR is stable for both. For recipients, it's just the same. If you have received the kidney from a young donor, your GFR is better compared to an old living donor, but is stable for 10 years and more. Proteinuria, another point of controversy. Is there a maximum proteinuria? It's totally different center to center. Guidelines. For KDIGO guidelines, the maximum albuminuria is 100 milligrams per day. But if you move to British guidelines, the maximum albuminuria is, instead of 100, is 300 milligrams per day. And for the rest of guidelines, it's also 300 milligrams per day. What has happened? I'll show you the Spanish registry for living donation. 2,000 living donors in this period of time. 9% of them had proteinuria. And the mean proteinuria for these real living donors was 236. But if you look at the standard deviation, you can notice that some of them had proteinuria greater than 300. That was a contraindication, but I am sure that our nephrologists individualize case by case. We have been using also donors with cardiovascular risk, smokers, 10%, arterial hypertension, 10%, but very well controlled at the moment of donation, systolic and diastolic blood pressure, with other diseases that I am going to comment, 17%, with dyslipidemia, 44%. Here are the associated diseases in our real donors, real living donors: arterial hypertension, 200, dyslipidemia, obesity, kidney lithiasis, depression, hypothyroidism. I'm sure that these donors 10 years ago were not real living donors. Moving to the infections, we are only using donors, living donors with positivities for CMV or Epstein-Barr, and we are not using donors with HIV or hepatitis C or B virus. But there are different papers that have started to publish different experiences in some hospitals using HIV positive living donors for HIV recipients. Why? Because previous experiences, especially in South Africa, demonstrated that using disease organ donors positive for HIV were very useful for HIV recipients, and now they are using this policy for living donors. And also, it seems incredible using hepatitis C virus positive living donors for HCV positive or negative recipients receiving an organ for HCV positive living donors. Tumors. The majority of centers are not accepting donors with renal tumors, but the initial publications, this is one of them in 2009, demonstrated that small tumors, the majority less than 2 centimeters, that are in the kidney of the potential living donor could be removed after nephrectomy and transplanted with good results. These are just the initial 5 patients. And now, it just been published 2 years ago, this systematic review for living donors with small tumors that have been used for renal transplant. 19 centers explaining their experiences with good results. In this case, 100 renal transplant and just 1 local relapse of the tumor. Donor lithiasis. Also, the majority of centers are not accepting donors with previous stones. But guidelines are saying, okay, you can consider these potential living donors. If there is absence of significant metabolic abnormality, you can consider this donor for donation. You have to give them, donor and recipient, a full counseling. If you have doubts, please give the advice of a specialist in stone disease. But finally, if you have unilateral kidney stone, which kidney are you going to choose? Of course, for transplantation, the kidney with the stone, and our donor has to be free of stones. But you have to consider this possibility. And also many publications, in this case with long-term follow-up, more than 10 years, explaining that donors after donation can be maintained free of relapses of these stones. Donor obesity, the last 2 points I have. A maximum BMI for our potential living donors. According guidelines, BMI more than 30, you have to individualize. And especially between 30 and 35, you can decide depending of the donor and also the recipient. More than 35 for the majority of countries and guidelines, it's an absolute contraindication. But you know that, for instance, in USA, they are using obese donors with BMI 40 or more than 40 kilograms per square meter. Of course, you have to explain to your donor that if he's obese, it has an increased risk of perioperative complications and also more risk of developing chronic renal failure. And this is a very explaining slide. If you compare obese living donors with non-obese living donors, the possibility of post-donation end-stage renal disease is different, but not at the beginning. You have to wait 10, 15, or 20 years to be how the curves are divided. If you are an obese living donor, you have an increase in your possibilities of developing chronic renal failure. You have to know that before donation. In my country, the mean BMI is 26, and just 16% of our patients with BMI over 30. The majority 31, 32. We are not using donors with more than 35. And the final point I would like to comment is donor diabetes is probably the one that has changed the more. 5 years, 10 years ago, it was impossible to think that a diabetic patient could become a living donor. At this moment, type 1 diabetes remains as an absolute contraindication, but guidelines, not center guidelines, say that pre-diabetes or type 2 diabetes should be individualized, probably depending on the age of the donor. If you are 70, 75 years old, perhaps the possibility of developing diabetes or developing diabetic nephropathy are low, and you can be used as a living donor. The British transplant guidelines also contemplate this possibility. The advice is to use a diabetes risk calculator to inform the donor, and then a very careful evaluation, of course. And this paper from Japan reflects what happens in real life. In Japan, diabetes is a contraindication, absolute contraindication for living donation. But they knew that some patients with diabetes, normal renal function, no albuminuria, if they suffer a nephrectomy because of a tumor, the long-term evolution of the remaining kidney was good. And they decided to convert from an absolute contraindication to a relative contraindication and to accept diabetic donors for the living donor program. And look at here what happens 1 year after donation when you compare living donors, non-diabetic with diabetic living donors. GFR is the same, and also on the right at the end of the follow-up, but just 5 years. In my opinion, we need much more. 15 or 20 years after donation. And also comparing albuminuria, non-diabetic and diabetic patients was just the same 1 year after donation and 5 years later. To conclude, there is a new kind of living donors that could be called expanded criteria living donors. The threshold to accept these donors is different, totally different, center to center, country to country, and continent to continent. Low and medium-term results are satisfactory for donor and recipient. But of course, we need long-term follow-up to have more conclusions. I think we have to repeat this talk in 10 years, not just now. And donor and recipient, of course, have to be totally informed about the potential risk for both. And that's all. Thank you very much for your attention.
Paolo, are you up for introducing the next speaker and thanking Lluís, or should I?
Okay. So the next speaker is Enrico Benedetti from the University of Chicago. He's a surgeon, he's a very well-known surgeon, and he has developed laparoscopic and robotic surgery in kidney transplantation. So I think he will tell us the progress in this area also. Enrico?
Thank you, Paolo. Thank you for the invitation in this interesting panel. I think Dr. Guirado will not be very happy with me by the end of the presentation, but I will present our experience in Chicago. So, of course, the donor safety is of paramount importance when we do living donor kidney transplant. And I believe that the surgical technique must provide a cosmetically appealing result, minimal pain, optimal functional outcome for the donor, short donor stay, and of course, integrity of the allograft for the recipient, despite anatomical complexity. Dr. Lloyd Ratner has been really the person that has helped us to achieve all these goals with his publication in November '95, showing the first laparoscopic live donor nephrectomy, which was successful but heavily criticized at the time. But many people pick up on what he did, and as you can see, the introduction of laparoscopic donor nephrectomy has increased the donation, at least in the United States, to the level of approximately 6,000 donors per year. In 2019, there was the highest number of donations in the US. We had 6,700 donors versus 30,000 cadaveric. I think now it's been well demonstrated that the complication rate are similar compared to open donation. We have many single center experience, for example, this one at Northwestern with 1,200 laparoscopic donor nephrectomy. Or the Mayo Clinic, another 1,300, which show that you can use indifferently left or right, although many people procure preferentially the left, like in open surgery, and multiple renal artery are certainly not a contraindication to use laparoscopic technique. I would say at this point, laparoscopic donor nephrectomy is universal in the United States. The learning curve is not simple and has been assessed between 60 to 90 cases to achieve proficiency compared to a very well-established surgeon. But here we go with what Dr. Guirado was alluding to. The United States is different from Europe. You can tell from 1999 to 2017, there's been an explosion of an epidemic of obesity. These are not a political party. These are actually data that show that in 2017, more than 35% of the patients, for example, in Alabama, had a BMI greater than 30. In Illinois, where I live and work, is red. 30 to 35% of the patients have a BMI greater than 30. Our bariatric surgery program does 500 cases a year. It's a different world. I'm European from Italy, and it's always impressive when I go back home that everybody seems to be fit. The US have a big problem with obesity. So in a city like Chicago, if you apply the standard limitation of BMI, you will lose about a third of the potential family that wish to help their relative or their friend with a living donation. We turn to robotic surgery early on for some consideration. The learning curve is shorter. In our experience, about 12 to 15 cases. Stability of the camera, magnification with 3D vision, and the rotational capability of the instrument. There is some mechanical advantage. And again, my presentation is certainly not aimed to say that it's better than laparoscopy. In good hands, laparoscopy is as good. But maybe in a case mix in which we have a lot of obese donor, robotic may make a difference. We start early. In 2001, the robot was introduced and approved by the FDA in August 2000. We bought the first system in the world, so we have a long-term experience with robotic system, and we had a favorable initial experience, which we continue. I will show you a brief video of the operation. It's done with the end assist technique, which in the US is becoming more popular after publication of some series in which has been shown to reduce the rate of conversion to open. So one of my partner will assist with retraction and rapid extraction of the kidney. The advantage of the end to me is donor safety mostly. In case of bleeding, having a hand inside will pretty much eliminate any catastrophic bleeding, even if coming from the renal artery. In this case, we are just dissecting and exposing the ureter on the left side. It's a left nephrectomy. The procedure is absolutely identical to laparoscopy. As you can see, we are mobilizing the ureter past the junction with the iliac vessel. We are following up toward the kidney, the gonadal vein as a guidance to identify then the renal vein. And here you start having some advantage of robotics. Applying the clip is very easy with the robot because they have full articulation. We use this simple instrument we call the hook to dissect without touching, and it's precise and efficient. The cost of the procedure in our center is slightly higher than laparoscopy, not much different. A little bit more expensive than open, but nobody does open anymore. The dissection is continued on top, mobilizing the upper pole of the kidney, and the ureter is double clip and transected just at the level of the junction with the iliac vessel. And then we retract the kidney medially and mobilize the lateral aspect of the kidney and exposing the renal artery, in this case, a single renal artery case, retracting the kidney medially. In experience end, this is a procedure that we do in less than an hour. We, of course, have a junior faculty that take a little longer, but the renal artery is dissected with no-touch technique using the hook all the way down to the takeoff from the aorta. And now the rest is mobilized, TA stapler to place the clip so we can inspect the stapler line. And then we cut sharply with robotic scissor. We stapler the renal vein, and then the assistant end is already in the abdomen. So it's a pretty rapid destruction, which is nearly immediate with small warm ischemia time. I will share with you our result using a series that we published recently in July 2020 in the Annals of Surgery. This series is about 1,090 donor nephrectomy cases from September 2000 to December 2017. We did an additional 340 in the last few years with similar results. That's our typical case mix. As you can see, we have a lot of diversity in Chicago. In cadaver, up to 55% of our patients are African American. In this series, about a third, that reflect exactly the composition of the city of Chicago. Here's the BMI. Dr. Guirado may not want to look, but we had only 25% with normal BMI. And 25 to 29, 35%, 30 to 35, 25%. Then we had some percent of super obese. We use a limit of BMI of 45 in our center. These are typical 24% multiple arteries. This is some intraoperative finding. But I think the main message I would like to show you are in the next few slides. We had a low intraoperative blood loss. We transfused 4 patients. The last one was in 2007, in fact. We had some conversion. The last one was in 2007. Lately, we have been quite successful, even in a situation with multiple artery and larger donor. Our length of stay is 3 days, with 7% readmission. These are some of the complications, mostly grade 1 and grade 2. But this is the slides I like to bring to your attention because Dr. Guirado correctly stated that the risk of technical complication has been historically greater in obese donor. And I'm, of course, very concerned on his slides that show that obese donor have, in the long term, a higher risk of developing renal failure. Our policy is that we use IUXL for the evaluation of all the obese donor. We accept only very high GFR using some life statistics like he did. We avoid any additional risk factor. So we do not accept even borderline hypertension, even glucose intolerance. They must be otherwise perfect. And with this criteria, we have now follow-up in some of them up to 20 years. We have done fairly well. In particular, no one of these our obese donor has required dialysis. We had few that mostly relative to patients with the glomerular that did develop it. But if you look at this, we divided in 5 classes. Normal, pre-obese, up to class 3 BMI greater than 40, and comparing everything that we studied. And I want to show you that African American in particular have a high rate of obesity. Yeah? We did not show any significant difference in the length of surgery, percent of conversion, warm ischemia time, estimated blood loss, transfusion. You can see class 2, class 3 never had transfusion. Length of stay. Actually, they went up a little faster than the other. So the complication, again, non-statistically significant in all the 4 classes. So I don't want to minimize the concern that Dr. Guirado expressed. We do have the concern, and we are trying to do our best to avoid at least overlapping of risk factor. But at least we can reassure that with our robotic technique, we did not notice any difference in surgical complication in these 4 groups, actually 5 groups of people. Neither in the serum creatinine at 1 year. We studied them the best we could. Of course, Dr. Guirado is right. We need to wait maybe longer time. But with a follow-up well over 10 years, we could not demonstrate a significant rate of progression to proteinuria, hypertension, renal failure, or need for dialysis. This is a table that compares our current series with 5 laparoscopic series that had in common to have at least 500 cases. And as you can see, now we compare favorably with those series that are mostly done, I'm familiar with Dr. Leventhal, mostly on patients with BMI less than 30. So overall, we have been pleased with our technique. We found that it's easy to teach to junior faculty and take less time for them to become proficient, and has helped us to expand the ability to donate to a population that is typically neglected. In a city with a third of the population being morbidly obese, it's difficult to say no all the time, I believe. So in summary, I would say that in our end, robotic living donor nephrectomy has been a safe technique. Sure, there's an advantage in a shorter learning curve. The operative time, you can show it faster if you compare with in obese individual. In a patient with normal weight, you cannot show much of a difference. And I believe that the technique is particularly relevant in countries like the US, where obesity is so prevalent. Thank you very much.
Thank you very much, Enrico, for this fantastic talk and impressive data. We have 2 more minutes, and there are some questions in the Q&A already, so please put your questions in there. And the first question is from Julie Hill that I would like to ask Lluís to comment on, and any other panelists. Is there any guidance on accepting young donors from 18 to 29, for example? Because more and more seem to come forward, but people do worry. And I think this is very important because this might determine as to whether living donors are encouraged or discouraged from donating. So what's your view on that, Lluís?
Well, we don't like to accept such young potential living donors. I can tell you that in my hospital, we have just accepted 2 or 3 of them, and we have performed around 600 living donors. But you have to individualize. If you have the legal age, more than 18, you can donate. But normally, 99% of cases, parents refuse donation from sons. And also, if it's the brother or sister, the recipient, parents appear and say, no, it's not for you, it's my responsibility, your brother or sister. Then, in the majority of cases, we refuse these donors, but they have the legal right to donate. Of course, you need a very, very good donor, and for cases of hypersensitized recipients or something like that. No diabetes, no obesity, no hypertension, no nothing. It has to be a pure, good donor.
So in general, you would not discourage young people for the long-term risk unless they have comorbidities.
No, but we try always to discourage these young people. My comment is that we have performed 600 living donors, and just 3-4 of them were younger than 30, because we try always to discourage these recipients, but they have the right to donate if they don't have contraindications.
I would agree with you that if there is an older donor, for example, a parent in one generation older, that would be the preferred one. But I would not discourage people in general, but that seems to be happening quite a bit, given the data that are coming out. We have to move on, but we'll get back to that hopefully with the rest of the Q&A. Thank you, Lluís. So it's a real pleasure to introduce Emanuele Cozzi, who's an old friend in xenotransplantation. But more importantly, he's a clinical immunologist, and he's providing advice to the whole transplant community in Padova, the Italian National Transplant Center, and even to the Pope in the Vatican for any xenotransplant related issues, and the Council of Europe. So Emanuele, please enlighten us about how we can overcome the immunological barriers in living donor kidney transplant.
Thank you, Frank. Can you hear me? Yeah? Yeah, thank you, Frank. And I would like to thank also Paolo and Isot for inviting me to this very interesting seminar where I learned a lot of things already. So my role today will be to speak about living donor and in particular overcoming the immunological barrier in living donor kidney transplantation. So these are my conflicts of interest, possibly. Just for this talk, I will raise questions and also I will, of course, share with you my possible answer. Which immunological barriers are we referring to today? Well, those of you who work in the kidney transplantation field know very well that the two principal incompatibility from an immunological standpoint is ABO incompatibility and HLA incompatibility. But this slide was wants only to remind us that there are new possible immunological barriers. I will not touch on them tonight, but we have to take into possibly due consideration in the near future. ABO incompatibility, so the first question is how often do we find ourselves where living donor and recipient are ABO incompatible? So this is a slide that shows the trend and the prevalence of ABO blood groups across the European population. And what we see here is that 40% of the potential blood donors are group O, and the potential percentage of the population, 40% are blood group O, 45 blood group A, 10% blood group B, and blood group AB are 5%. The important thing is that in any living donor recipient pair, the chances of being ABO incompatible is 35%, is 1 in 3. It's a data we have known for quite some time, and indeed it is the case. So we have to remember here that it is a very, very frequent situation where we deal with living donor transplantation. What are the options that we may use to overcome this incompatible living donor recipient pair? And here we have basically two broad strategies. The first one is desensitization, and the second one is based on the so-called kidney exchange programs. And I will touch a little bit on both just to let you perceive that in fact living donor transplantation does with incompatible donors may rely today on very interesting tools. So first of all, desensitization. And for desensitization, the basic principle is to remove the antibody, first of all, and second, to somehow increase the immunosuppression. So these are the peculiar steps that we will have to put in place to go ahead with ABO incompatible transplantation. In terms of desensitization in ABO incompatible transplantation, we do have essentially three important tools. Often we use rituximab, which is an anti-CD20 monoclonal antibody, as you know, and we tend to give it usually at least a month prior to proceeding with ABO incompatible transplantation. And then what we all know is that as the damage is mediated by the pre-existing antibodies against the potential donor ABO antigens, we will have to remove such titers of antibody. They will have to go down to a certain target that will vary according to the different measurement we use, but for sure we need to remove these antibodies. After that, we need to make sure that our recipient is exposed to a good induction treatment. It is preferable but not indispensable. And then we may have, and as it is written here, on demand, we may have to face the need to remove antibody. The important thing that many of you will know is that in contrast to HLA incompatible transplants, ABO incompatible transplants at some stage may rely on a situation which is called accommodation, where the de novo appearance of anti-blood group antigen will not be associated with an immunological attack and damage to the graft, which is a very peculiar situation when dealing with ABO incompatible transplant only. Now, if we look at the outcomes of ABO incompatible renal transplantation, and here the majority of the data, of course, will rely from ABO incompatible transplant that have been generated using ABO incompatible organs from deceased donor, but the outcome is still very much of great impact, and I think we have to take home important messages. The first one is that I will only show you two key review articles, which are meta-analyses that were published in the last 3 years. Okay, this one was published on CJAS, and they want to compare the outcome of ABO incompatible transplant versus the outcome of ABO compatible transplant. As I said, it's a retrospective meta-analysis. The figures are important, and what we see, I have just highlighted them in red because they want to show that for any of the key data that have been provided to the readership of this article, and the data with regard to 1-year survival, the infectious cause of death of recipient, antibody-mediated rejection, and non-viral infection, as you will see, ABO incompatible transplant is always associated with a significantly worse outcome in terms of 1-year graft survival, in terms of infectious causes of death, almost 4 times as many deaths in ABO incompatible transplant, antibody-mediated rejection 5 times as much, and a non-viral infection twice as much. So clearly, ABO incompatible transplantation works, but by far the good outcome is there, but it is inferior to ABO compatible transplant. Now, a similar study, I don't go into the details, as was published under 2 years ago by the Cambridge group, and this is a study that wanted to look at the it's on the Lancet paper at a similar retrospective analysis, and again they report excess mortality and loss of kidney within the first 3 years in ABO incompatible transplant compared to ABO compatible transplant. Okay, then the data somehow improves from 5 years onwards, and the authors feel very strongly that the findings they provide would indicate that kidney exchange program should be definitely favored. Now, such an article was somehow the subject of a few concerns that possibly the tone used by the article were possibly a bit too strong. And for instance, here, Alexandre Loupy, as you know, the group in Paris, but associated with important people like Mark Stigall and Bob Montgomery, that at the time used to be in Baltimore, they say that perhaps the tone that were used were a bit too strong and they should be moderated. Okay, so in any case, it is unquestionable that the results are possibly not as good. Now, the important thing is that here, thanks to Paolo Rigotti, our creator of today's session, I have the privilege to share here a couple of slides that regards the largest series in Italy of ABO incompatible renal transplant. They are the transplant that were performed by Paolo and his team here at the University Hospital in Padova. And what we see here is that basically the ABO incompatible transplant were started in Padova in 2010. And for the last 11 years altogether, Paolo and the whole team in Padova was able to reach the 100 overall number of ABO incompatible transplant, which is quite good. But the interesting thing is that, as you will see, the trend has been progressively increasing, okay? And we are talking about living donors only here. And you will see that at some stage, 23 transplants, which account for roughly 50% of the overall number of living donor transplant, 50% were from ABO incompatible donors. And then progressively, with time, as you have seen, this percentage went down to 23, 20, 14, 16%. And it's really dropping, the number of ABO incompatible transplant. The results were altogether not bad, but we have already the warnings that were shared with our previous article, where they clearly show that there are some graft losses. Yes, in this case, 3% due to antibody-mediated rejection. There is exposure to a higher degree of immunosuppression, so neoplasia and sepsis is there. But altogether, the function is not bad, and the 5-year survival for the 30% for the 30 recipient that reached the 5-year survival of the graft, the creatinine was really satisfactory. But on the other hand, we have other options, as we said, for ABO-incompatible transplant, and in particular, the kidney exchange program. I will only briefly touch base, but I will not go into the detail for the sake of time, of course. So basically, kidney exchange program, essentially 3 tools: crossover, Samaritan donor, and DEC, the so-called deceased donor initiated chains, where the group here in Padova, and in particular the role of Lucrezia Firan has been very important to start this important program here in Padova. Kidney pair donation, very simple. As you see, we have 2 couple here where the living donor is incompatible with his recipient. And the same situation happened in another context of another pair donor recipient. And as you see, we will do an exchange program. This is something which was launched a long time ago, and it works very well. The important thing is the number of combinations. By pooling the pairs of incompatible donor recipient combinations, you will see that if we have only 10 pairs, we can go up to 45 combinations. But if we increase by 10 the number of pairs that will be in this pool of a kidney exchange program, you will see that by increasing by 10 the pair, we increase by a factor of 110 times the number of possible combinations. So this is clearly a very clever, a very well working instrument, okay, that will lead to a transplant in normal ABO compatible conditions. Then another thing I just mentioned to you is the deceased donor initiated chain. This is the paper that was recently published by Lucrezia, and clearly it shows that we can possibly use deceased donor to trigger and start possible incompatible pair. And at the end of the day, we are left with a living donor, donor C, that will give back to the wait list the donor, the kidney that was originally put in the chain that was created, with the advantage, of course, of having a donor possibly of better quality. Okay, so now what happens on the front of HLA incompatibility? Some of the things I said are valid also for HLA incompatibility. How frequent is incompatibility in living, HLA incompatibility in living donor kidney transplantation? We have indirect figures, and I just want to bring here to your attention an interesting paper that in fact pools both HLA incompatible and ABO incompatible transplant as of 2017 in the United Kingdom. And as you see, up to 10% of living donor transplant were undertaken in the context of either an HLA incompatible or ABO incompatible situation, or both. So that's an important contribution. Now, how frequent is HLA incompatible, the risk of HLA incompatible transplant? So clearly it is very much also linked to the technology that is used to evaluate the state of sensitivity of this of these recipients. And in the same group of patients, I just want to remind you that the enhanced sensitivity of the technology we have in hand now allow us to identify as many of 77% of the patients in this study of a few years back in United States that were somehow waiting for a kidney transplant and were immunized, while only 5% were indeed positive at a CDC technique. Now, other data that comes from patients that are waiting for a transplant. So here we are not patients waiting for a living donor, but altogether the figures are worrying and worrisome. In Italy, we have 50% of the patients who are waiting for the transplant in Italy on the active list, 50% have anti-HLA antibody. And the most important figure, which I think speaks for itself, we do have 9% of the patients on the waiting list that are immunized with a PRA of 100%, which is clearly showing that these patients are quite frequent, even amongst people who potentially have a living donor available. Which are the options for HLA incompatible pairs? Well, the principles are the same: desensitization and kidney exchange program. I will not go into the detail, but just remind you that the key people who have been working in this field, essentially Stanley Jordan and Montgomery, have been proposing an important approach, which is either on high-dose immunoglobulin or a well-known program with the plasmapheresis combined with CMV-IG or IVIG, as in the case of Montgomery. And we do have other tools, including, of course, immunopheresis, bortezomib, eculizumab, imlifidase, and other new approaches that could be put in the desensitization protocol that are being generated in the pipeline. Careful, though. Because although in the paper reported a few years back by the Montgomery's group and collaborators that deals with the data in North America, there seems to be, they reported that there is survival benefit with doing HLA incompatible live transplantation. The same thing was not observed in the United Kingdom. An important thing, though, that was observed by many other groups is that when we desensitize a recipient, we increase the risk of having early appearance of chronic damage in the graft that is given to a desensitized recipient. And here in the study, which is very important, it shows that 50% of the patients on the waiting list that have been transplanted and undergo kidney protocol biopsy, as you will see, 50% do have as early as 18 months after transplantation receiving an HLA incompatible transplant, they will present lesions that are compatible with already chronic lesions, and the fate of these kidneys will not be as good as expected. Kidney exchange program, I will not go into the details. They are the same tool we discussed before for ABO incompatible. And here, the key principle I would like you to take home is that the objective of underlying kidney exchange program is to achieve outcomes as close as possible to the outcomes we are witnessing with HLA compatible kidney transplant without increasing the risk that are associated with incompatible transplant. And I will stop here. This is my last slide, where I want to remind you 4 important things. Living donors are unquestionably a unique source of organs to supplement the pool of kidneys for transplantation, which is clearly insufficient. We have to remember here, though, that at least 40% of living donors will be immunologically incompatible with their intended recipients. So we have to do something. And for sure, desensitization is a good step forward, okay? It's a successful approach. However, as I showed you, it is associated with worse graft outcome and also an increased recipient mortality. This has been shown by many studies. And I am personally convinced that although desensitization remains an important tool, we really have the privilege today to be able to rely on kidney exchange program. In my view, they appear as critical tools to increase access to transplantation and improve results in terms of safety and function to reach those that possibly are those that we are witnessing in HLA or ABO compatible living donor recipient transplantation. And I will stop here, and thanks for your attention.
Thank you very much, Emanuele, for this wonderful talk. And I think we do not have a lot of time for questions. Luckily, the speakers have already answered most of them. Just to give you a heads up that the actual recording will be published through the ESOP social media and other media platforms. And also next week, we're going to have a famous Twitter chat, ESOP chat, on this very topic. So please join us there as well. Please do answer the questions and keep them coming. And we try to answer all of them over email or in a different format, or on Twitter later on next week. Paolo, can I give the word back to you, please, as chair of this meeting?
Thank you. Well, I think we have heard about three very important aspects: the donor selection, the surgery, and the immunology. And I think that improving these three aspects really will let us to improve the rate of living kidney donation that we absolutely need, because I think every country has problems to give an answer to the patients in the waiting list for disease donor. So I hope I thank all the three speakers. And
Paolo, can I interrupt you? I've just heard good news. We can extend for 5 more minutes to get some discussion, which I really, really love to.
mm-hmm.
So shall we do that?
Yeah. Sure.
Okay. Enrico, quick question for you from Lucrezia. In case, what's the learning curve for robotic versus laparoscopic? So in other words, do the surgeons who do robotic nephrectomy in live donors also have experience in laparoscopic nephrectomy before they embark on the robot?
Yeah, we stopped doing laparoscopic donor nephrectomy in 2000. So all of the surgeons that we trained since have no experience in laparoscopic donor nephrectomy or open nephrectomy. As I show you in the literature, they pick 60 to 90 cases to reach sort of optimal result comparable to expert. And we trained over the years 6 different surgeons, and they took about 12 to 15 cases to reach a time comparable and a rate of complication similar to people with more experience. We tend to actually still maintain the case in the hand of the most experienced surgeon, because that's my worst nightmare, a donor complication. And we try to really keep the group doing it pretty senior and experienced.
And what would you say to people in other parts of Europe where even open donor nephrectomy is still the gold standard and where money might be an issue? Is that a barrier for robotic live donor nephrectomy?
Well, depends if your center is already using a robot and there is a good volume. They say about 250 to 300 cases per year. The added cost compared to laparoscopy is not that great. Open surgery is still a lot cheaper, no doubt. The future clearly show that many companies are entering the robotic market that has been a monopoly for the last 20 years. And I have, of course, the hope that the cost will decrease. Still, I understand that it's a luxury that maybe is not possible in some of the countries. On the other hand, again, if you don't do obese individual, I don't see a huge advantage to do the laparoscopic nephrectomy versus robotic.
Thank you for that. Lluís, I know you have answered some questions already privately, but perhaps good to share. What is important? This is Naveen Kumar asking, what will be your approach for donor GFR? Should we do eGFR versus measured GFR? And which method for measured GFR?
Yes, thank you for the question. We have changed our approach. At this moment, we are just using estimated GFR. In 2 occasions, if both are normal, we stop here and we don't use 24 hours urines. In case of any doubt about the result, then we use isotopes to measure renal function. But normally, estimated GFR with CKD epi is enough for us.
Thank you. Question for Emanuele, from me actually, just live. You highlighted the debate for incompatible transplants versus kidney pad exchange or sharing schemes. Obviously, it depends a little bit where you are in the world, or in Europe especially, if you have a developed program for kidney exchange or not. But what is the place if you are living in a perfect country with desensitization programs, ABO incompatible programs, and kidney sharing schemes? What's the place for going ahead with incompatible transplantation in your view?
Can I add a question to Emanuele? Emanuele, we always talk about ABO incompatible, the results on ABO incompatible, but we know that there are major differences on ABO incompatible. It depends on the title of isoammoagglutinin. So is it right to consider all the results for all the ABO, or should we consider this?
Okay, so I will answer to both questions. The first one, as a transplant immunologist, I have to remind everybody that the immune system, on the contrary of myself, has an excellent memory. So what it means is, as we do the vaccination for polio and we retain the immune response for the whole duration of our life, we have to remember that the same, not always, but may occur also in immunized patients as a consequence of prior pregnancies or other immunological events. So the first thing is that this is bad, and whatever will happen with desensitization, yes or no, good immunosuppression, yes or no, the immune system is likely, not surely, is likely to have memory, okay? So that is, to me as a transplant immunologist, is a contraindication to go ahead with desensitization if we have other tools. And it looks like recently, also thanks to the involvement of many of us, of you, and especially also Paolo and Lucrezia Furian, we have been very fortunate to develop these programs that will circumnavigate and avoid the HLA or the ABO incompatibility. So in the ideal world, I know, Frank, the ideal world does not exist, but if we can just try to remember, immunology has a memory, try to avoid and go into unlucky events, number one. But Paolo is raising another issue. We have to distinguish ABO incompatibility from HLA incompatibility. ABO incompatibility, as I said before, can eventually lead to accommodation, which is a kind of a tolerance-like approach, which has never been documented for HLA incompatibility. So the first difference is that desensitization, perhaps yes, but preferably, definitely for ABO incompatibility and not for HLA, if possible. And also there in the risk stratification, Paolo is raising an important issue. Now we know that people who have anti-blood group antibodies at low titers, they are potentially going to have as good results as living donors with an ABO compatible situation. So also there, to have a titer of anti-ABO blood group proteins, sugar of 1 in 32 is good. And if you have 1 in 256 is bad. So also there we have to risk stratify. I don't feel like saying ABO incompatibility is always bad. No, I totally agree with Paolo. Low titers of ABO incompatibility is compatible with a normal approach to transplantation and good long-term survival, which is comparable to ABO compatible transplant. Thank you.
Thank you. We're almost done in terms of time we have for the webinar, and we'd really like to do the poll to see how happy you were with this webinar and give us your feedback. So can I ask, there it is already. And let's vote if we can. I can't vote, unfortunately. And hopefully we're going to see the results, and we will have to reflect, Paolo, on what people think about this.
No feedback.
Ah, there you go.
Wow.
Good.
Wow.
Good.
So I would say 96% useful or very useful.
Extremely.
And some people just know everything already, of course. So that's great.
Very kind people.
Very kind.
Excellent.
Thank you. Thank you all very much. And as Paolo already thanked all the speakers and people who asked questions, we'd like to end here and see you all in Milan or on ESOT Chat on the Twitter.
Thank
Ciao.
you.
Thank you. Ciao. Ciao,
Bye.
Frank. Ciao, Lluís.
Thank you.
Bye.